Hey everyone, Lizzie Barrett here, the nurse educator out at Nepean Hospital in the intensive care unit. And today I'm going to be just doing a short lecture on awake proning. So I guess the normal caveats that I've talked about in all of the other videos, this is generic in nature. Please refer to your local policies, procedures and guidelines if this is something that you're doing to patients in your ward or unit. And I am aware that this is something reasonably new for lots of people. So you might not actually have any formal, I guess, guidelines around it, but having a conversation with your management, your medical officers around how you're potentially going to do this and what documents you may be developing in the future, just so everyone's on the same page. It's generic in nature. So again, there's going to be slight differences from location to location, and some of that is going to be dependent on equipment, and some of that's going to be dependent on resources, people resources, and the skill of the people involved and their experience with this procedure. This is not designed for intensive care units, although we do awake proning in intensive care units, but I think most intensive care units would be reasonably familiar with proning and should have their own again, procedure documents around that. So we're not talking about proning sedated, intubated patients. We're talking about proning awake patients. All right, so proning, what is it? Proning is where we nurse someone on their stomach rather than on their back. So it's us turning someone onto their front rather than having them in the supine position. And it's something that we've done in the intensive care world for a number of decades, but probably reasonably frequently since the kind of, I think the seminal paper came out in 2013 looking at proning in ARDS, so patients with acute respiratory distress syndrome. So it's something that we've used pretty frequently since then. So over the last 8 to 10 years or so, it's been part of routine practice in intensive care units. However, it is something that we normally do on patients who are sedated, paralysed and intubated on mechanical ventilation. And obviously when someone's receiving that level of intervention and has that many lines and tubes in place, it's actually quite a risky procedure. And there's some really significant, considerations we need to think about before we do it in that patient population, or when we are doing it in that patient population, because the procedure itself carries quite significant risk. We dislodge an airway, we pull out lines, the patient has cardiac arrest. We are talking about very, very unwell people. So I guess we're used to doing it in that cohort. What's happened with patients in COVID-19 world is our colleagues overseas have, found that by proning patients awake, at least anecdotally, they're finding they're staving off the need for intubation and therefore mechanical ventilation. And that's always a good thing, because we know that if we have to put a breathing tube into someone's lung and put them on a mechanical ventilator, it really significantly impacts on their mortality and their long-term morbidity. So they're much more likely to die just with that single intervention alone. They're much more likely to die. And if they do survive, then the potential for long-term consequences is really quite significant. So if we can do things in the early stages of the illness to try and prevent that person from needing mechanical ventilation invasively, then that's a really good thing. And so the things that we are seeing that we think work, and again, a lot of the evidence at the moment is anecdotal, although there are some papers starting to come out, particularly from our colleagues in the States and the UK who've seen much higher caseloads than us, is that if by providing good access to good quality non-invasive ventilation, high flow nasal prongs and awake proning, there are, that is of benefit. So why does placing a patient on their stomach actually work? What is it about proning that makes a difference? Well, it fundamentally comes down to the notion of ventilation and perfusion. So if we think about ventilation as the transfer of oxygen into the alveoli during inspiration, so that's what we mean when we're talking about ventilation. And perfusion, we're talking about the flow of blood to the alveolar capillaries. So if you remember back to some of the previous lectures that I've done around NIV, you have your alveoli, and around those alveoli, you've got this little capillary bed. So as the alveoli open during inspiration, you get this transfer of oxygen and CO2. So we, in the perfusion component of ventilation and perfusion, we need good blood flow to those capillary beds. So we can have an issue with ventilation where we're not getting adequate ventilation. We can have an issue with perfusion where we're not getting adequate blood flow to those capillaries, or we can have an issue with both. And when we nurse someone on their back, we actually get an issue with both. And nursing someone on their back is the traditional way of looking after someone. So if you think about the lungs, one of the largest components of our lungs is the dorsal component. So when I say the dorsal component, so let's wind it right back. Let's use really simple terminology for those of you who might not be familiar with these terms that we throw around. So the dorsal component is the bit at the back, so the posterior, the bit that's, if I was lying flat in a bed, it's the bit of the lung that's lying against the bed. So that's a really large component of lung. You've got to think about, when you think about your lungs in your chest wall, there's, you know, a whole heap of room at the front where your heart is. And so big areas of our lung fields are at our back. So when we nurse someone lying flat, or on their back, what we do is we take the heart and our abdominal organs, and basically all of the weight of those things squash the dorsal component of the lung, or that back component of our lung. It squashes it all down. And because it's squashed, those alveoli can't actually really open. And so we get an issue with ventilation, don't we? We can't really get oxygen into those alveoli to then get into the blood. And the problem is with that as well. So there's the ventilation component. We've squashed that area of lung and therefore squashed the alveoli. In addition, because we're nursing someone on their back, gravity, I guess, has an impact on our perfusion. So because the patient's lying flat, all the blood that's going to the lungs naturally goes to the low area, it goes to the back area because of gravity. And so we're supplying all of these capillary beds around those alveoli that can't open because we're squashing them. We're giving them lots and lots of blood because of gravity, but there's no oxygen to go into that blood. And the alveoli aren't opening, so we can't get the CO2 out of our blood to go into the alveoli. So we end up with what's called a ventilation perfusion mismatch. We're giving lots of perfusion to an area of the lung that's not ventilating. Those alveoli aren't opening because we're squashing them. So what happens is when we turn someone onto their front, and you can see that quite nicely in these images. So you can ignore this, sorry, my mouse has disappeared here. You can ignore this tube if you like. That's, you know, that's obviously an endotracheal tube, so that's a breathing tube that's going through someone's mouth into their lungs. But this picture is relevant regardless of whether that's there or not. When we turn someone onto their stomach, what we do is we allow that posterior, or the dorsal, or that back component of our lungs, the bit of the lungs that's on against our back, we allow that so that's the really large component of our lungs, we allow that to inflate and open up without the weight of our heart and other organs squashing it. So not only now do we have, I guess, those lung fields opening up and able to expand, and therefore the alveoli open to expand, we take the bit of lung that has the biggest bit of blood flow going to it, and we match that ventilation a little bit better. So yes, you're still going to get some, I guess, the gravity component of the blood's still going to go down, but we're actually now not squashing that front component of lungs with our heart. And again, this image, I don't know if I'm describing that very well, but this image probably speaks 1,000 words. So on our back, this big aspect of posterior dorsal lung that's being squashed by our heart, and in reality we often get weight coming up this way from our abdominal organs. And again, if someone's lying on the back, their heart's at the front here, we've got this downward pressure going against those dorsal components of lung and squashing down all those alveoli. So again, we've got squashed alveoli with lots of blood supply. But now we flip someone over, and the heart's actually, just because of where the heart's located in the chest, you're now actually not getting the same pressure down on lung fields. So we're displacing displacing that. And so that means that we actually have better perfusion. We have lung that's not being squashed. So hopefully all those alveoli, not only in our dorsal components of lung, although that's absolutely imperative, but across all fields of our lungs are now actually able to open much better. And you're matching your ventilation, your perfusion much more adequately. So that's, I guess, why we do proning. And you see, when you prone patients, you generally see an effect pretty quickly. Like I'm going to say within the first 5 or 10 minutes, it's patients generally tend to be responders or non-responders. And if they're going to respond, which is most people are responders, they respond very, very quickly. And certainly that's been my experience while looking after COVID patients. And when I've been proning awake patients who are in our intensive care unit with COVID, who are awake and conscious, when we've proned them, you see their numbers improve dramatically almost immediately. And I think that's one of the things that's really challenging and really unusual for us while we're nursing in these times, is that we're seeing patients with numbers that we, probably have typically not seen before, or ones, we're really not used to seeing this type of patient presentation. Your young, fit, healthy people who are sitting in your intensive care units, they're on 100% oxygen, they're sitting upright, they've got blue lips, they've got a respiratory rate of 50, and they've got oxygen saturations in, the low 80s or high 70s. 6 months ago, that would be a great, a patient would cause you a great deal of concern, but that's almost a typical looking picture these days in our intensive care units. And so, we all know that you can't go on forever with numbers like that. We do need to try and do something to try and improve that oxygenation. And again, access to good early non-invasive ventilation, high flow nasoprongs, and proning these people really, really can work. Okay, so in terms of awake proning, and I'm going to say this for me is the baseline criteria. I've done a bit of a look around, particularly again from our colleagues in the UK and in the States, and what their practice has been over the last 12 months or so, as this is something that they have done really frequently across all departments, emergency departments, ward environments, etc., to manage patients. So patients that we're awake proning, and again, in the emergency department or ward department, you kind of need ward-based areas. You need to meet this baseline criteria. It's not to say that we don't prone people who don't meet this, but the level of observation and the support required to prone someone who doesn't meet this baseline criteria is more significant, and the risk to the patient is more significant. So there needs to be additional resources to be able to prone them safely. So we need to do it with patients who are able to communicate and understand. We need to do this with patients who can rotate and adjust independently. We need to do this on patients who are hemodynamically stable, and we need to do this with patients who have no anticipated airway issues. And again, I'll just repeat, we do this with those who don't meet this baseline criteria, but it needs to be in an environment where they're being really closely monitored and watched, so somewhere like an intensive care unit. We've talked about this, the fact that it works, and I think there is some publications starting to come out that would that gives us the data that we need to kind of, I guess, prove what we anecdotally are already feeling. And certainly, if you start doing this, you will see people improve in front of your eyes. And yes, it's short term, so you get that kind of short term gratification, relief. Yes, you've improved their oxygenation, but we are seeing people stave off intubation and the need for mechanical ventilation, which is fantastic. So how do we actually do it? And I've just got a picture here. This would be a patient who's in intensive care being invasively ventilated, who's being nursed in the prone position. When we do this in intensive care, we often have a patient prone for 2/3 of a day before we then unprone them, and we would do it for a number of days in a row. For those patients who are awake and conscious, we do it for much shorter time frames. So 30 minutes would be a minimum. I know in my environment, we strongly encourage patients to stay prone for 2 hours at a time. And obviously, if they're uncomfortable or need to eat or drink, go to the bathroom, all that kind of stuff, that's completely fine. And where we're finding the best time to do it is overnight. So really encouraging people overnight to sleep on their stomachs. lots of people naturally sleep in that position, so it's actually it's very comfortable for them. It feels natural for them, and they're actually getting a better rest because they're in a position that they would they're more likely to be in at home. All right, so I guess, again, I've just put that caveat. If you need to assist someone to roll over into the prone position, you need more resources. There are extra safety considerations. So there's extra safety considerations for yourself and your team. So it's from a manual handling perspective, putting a patient who can't do it themselves into the prone position it's a high risk activity, and so there needs to be an appropriate plan in place of how you're going to do that, depending on what aids you use, the number of people you need involved. The more lines that someone has, again, the higher the risk involved to the patient. So we're talking about awake proning a patient who might be on a little bit of high flow or some non-invasive that we can potentially take off, pop them on a non-rebreather while we turn them over. It's not to say you have to. You can leave them on non-invasive or high flow while you roll them over. IV lines, it's always good to disconnect those if you can, and just to minimize the risk of losing those things. But let's talk through it step by step. So your very first thing, you need to explain the procedure to the patient. So you just need to explain to them that we've found that if you lie on your stomach for a period of time, it can actually improve your oxygen levels. And so would that be something that you'd be able or willing to try for us, because your numbers are very low and we want to try and get some more oxygen into your body and help heal your lungs and get you over this, very difficult place in your illness. Obviously, some people will go for it straight away because they're natural tummy liers, and that's a position that feels really comfortable for them. And some people aren't natural tummy liers, and you can kind of convince them to give it a go, and some people will tolerate it and some people won't. So I've had all of those circumstances happen to me. All we can do is try and hope for the best. If the patient has any IV lines attached or they're on NIV, remove what you can. And I would say as you become more familiar with this, you get more experienced, you can remove less and less because but certainly for the first couple of times that you're doing this, if you can remove things then safely, then remove them and then reconnect once the patient is over on their stomach. But you don't have to disconnect things. Again, it's just about that pre-planning, really thinking about, okay, well, how's their arm going to go that's got the IV line in to get them over to the other side? Where's the pump going to go? Things like that. We often have enough leeway on high flow nasoprong tubing and non-invasive ventilation tubing to, again, get them over. That's usually not too much of an issue. If your patient is being cardiac monitored, please remove those leads. Have a kidney dish of spare ECG dots beside the bed, because as the patient rolls from back to front and front to back, we're going to be changing those. So if the patient's lying on their front, we're going to put the ECG leads on their back. And if the patient's lying on their back, we're going to pop them on the front. We don't want to have those devices in an area where they're going to cause pressure injuries. So once you've removed whatever medical devices you can, you've maybe popped the patient on a non-rebreather mask, you've removed their cardiac monitoring leads, you're going to ask them to roll onto their front. And most people will be able to do this by themselves. I will say, again, this is anecdotal in my observation, our COVID patients are very unwell, they're very tachypneic, their oxygen is not, like their saturations are normally quite low, their work of breathing is really elevated, and even a very small maneuver like this, like literally just rolling, shuffling onto their side and then over onto their stomach, can really tire them. So you may see their work of breathing increase, you may see their tachypnea get worse, but hopefully once they're on their stomach, within about a minute they should settle and those symptoms should resolve and their oxygen levels should get markedly better. That would be an indication that they would be a responder. So once the patient's on their front, I guess our primary concern is to get them back onto whatever the oxygen delivery device or whatever non-invasive ventilation support they were receiving. So if that was normal nasal prongs or a Hudson mask, that's great. If it was high flow, get them back on their high flow. If it was CPAP or BiPAP, get them back on their CPAP or BiPAP. And this is where you might need to spend a bit of time getting them comfortable. So when we prone people in intensive care who are intubated and ventilated and sedated and paralyzed, when we roll them onto their stomach, we actually do a whole heap of propping with pillows. And that's because we don't want to squash the abdomen. We need to leave the abdomen hanging free. We need to try and prevent pressure injuries. The great thing about an awake patient is you don't have that same element of consideration. The patient's awake, they can tell you when they're getting uncomfortable, and they can tell you where they need pillows to be comfortable. So some people like a pillow still under their head, so with their head on the side, they have a little pillow underneath. Some people like a pillow under their ankles or shins, just to kind of keep that little bend in the knee and keep their feet off the end of the bed. That's totally patient dependent. It's about asking them what they need to feel comfortable, and that is similar when you get the NIV back on. So what way do they need to lie to make themselves comfortable? Now, if patients can't tolerate lying completely on their front, it might be that they just need to be propped up a little bit on one side with that hard plastic mask on their face. Maybe they're a little bit more kind of left or right lateral lying. That's fine, whatever works best for them. It's still achieving the same end effect with the lungs, which is freeing up that dorsal component of the lung, allowing all those alveoli to expand and getting good blood flow, or allowing that good blood flow to be matched with those nice expanded alveoli, so we can improve oxygenation and CO2 removal. Once we've got that oxygen delivery, whatever they're getting back on, and the patient's reasonably comfortable, putting their ECG dots back on the back, if they were receiving cardiac monitoring, and you put the leads on the same. It sounds silly, I know, but it's these practical things that trip us up. You know, right arm would go on their right shoulder, left arm would go on their left shoulder, etc., etc. So you don't need to reverse it or anything like that. And then finally, attach any IV lines you may have disconnected, or anything else you may have disconnected. Ensure they're covered. So whether it's just with a sheet or a sheet and a blanket, whatever they need to feel comfortable. From a nursing perspective, it's really, really important that the patient has a way to call you. So if they're not, if you're not nursing in an environment where you may maintain a direct line of sight, like an intensive care unit, they need to have access to a buzzer. Don't walk away. These patients don't have the luxury of being able to wave to you, like say their buzzer's dropped on the floor, or we forgot to give it to them, or something's happened. They can't catch your attention very easily because they are being nursed face down. So I guess providing patients a way to contact you is really important. Because if there's an issue, so how many of us walk past a 4-bedder room or walk past a bed space, now the corner of our eye, we see something that doesn't look right, and that alerts us to a problem. So again, we don't have the luxury of that with patients who are being nursed in the prone position. They're face down. We don't see those things that we use to identify problems. And yet patients can't signal us very easily. So very, 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 very important. That would probably be my biggest warning and biggest caveat in when you're doing awake proning. It's really important that patients come back frequently, and they need to come back for meals so they can eat and drink, for cares, so toileting, showering, you know, physio, things like that. And just for breaks, again, we need to minimize risks of pressure injuries. So let's move that position. And if you've got someone who responds really well, it might be great to have them in a left lateral lying, a prone position, so on their stomach, a right lateral lying before going back onto their back and sitting them up in a high Fowler's. So I guess the worst position in theory we can have a patient in is lying flat on their back. In reality, you see that with some people, that's how they oxygenate best. And there does come a point when we need to balance, you know, the need for numbers with the need for like what's in the best interest of the patient. So when someone is so hypoxic or their oxygen levels are so low, we do need to find that position that works best for the person. So yeah, I guess all in all, just make sure you're rotating positions reasonably frequently, and going back to the patient after, you know, whether it's a couple of hours or whatever, to see if they need a break. Can I help you roll back? Let's sit you up. Let's get a drink of water. Do you need to use the bathroom? All of those types of things. Okay, so there's a couple of resources that I found online. So awake proning, I guess, in the Australian setting is pretty new. We're very much looking to our colleagues overseas who've been doing this, you know, with, I guess, a reasonable amount of success over the last 12 months or so. I found these great videos that are just on YouTube. I think one's from the States, one's from the UK, and it's just their experience, and it's a practical demonstration of how they roll patients. Again, they've come from units or places that have obviously started doing it and then have developed their own local policies, procedures and guidelines. So that just be mindful of that. There might be some differences. And the other group of people that I would strongly support you reaching out and contacting if you're struggling with this is wherever you are, your local ICU, either education team or your CNCs. Most intensive care units prone people, like I said, on a reasonably regular basis, and would have documents that would help guide your practice. Yes, awake proning is something new for us, but it's actually much easier in lots of ways than proning someone who's unconscious and mechanically ventilated. But those education teams or CNCs are really good resource people to help you develop stuff if you want to develop stuff or talk through different issues that you may be having. So I hope you found this presentation really useful. I'm happy to hear other topic ideas if you've got them, and I can definitely put some stuff together for you. I hope you're all well and stay safe.